वो रिस्पॉन्स आया थे हाँ जी अच्छा hello hello everybody yes me is Zaid Akbar uh, instead of Dr. Hassan he's away on a workshop at the moment so I thought yeah they can hear me now yeah okay great thank you Dr. Hassan was supposed to give this lecture to you. Okay, we'll see you up there. Take a while. So he's busy in doing workshop in CPSB. So instead of him, I thought I'll just go and talk to you about some important topics. Uh, usually there are two questions from this section. So this is very important and quite common in surgical practice. It's regarding gallstone disease and its complications. I'm sure you know quite a bit about it, but I thought just to go through again to refresh, and some people will probably get some help in revising these important aspects of the general surgical practice, specialized surgery. We got usually two questions from this section. So I'll try to cover most of the aspects of this complications and the original disease. Usually there is a scenario that a 40-year-old lady, as you all know, gallstone disease is usually 5Fs, female 40 or 50, have this problems, flatulence, uh, uh, 50 years old, fat, and sometimes complicated with feces and flatulence as well, and fatty meals. But usually the scenarios like this, that a lady of 40 comes with epigastric and right upper quadrant pain of few hours duration after having a meal. And what do you think, just on this scenario, what are the differential diagnoses? And what you should keep in mind, if somebody comes with acute abdomen, acute pain in the epigastric and right upper quadrant region, and differential diagnosis which should come into your mind is it could be appendicitis. Sometimes you get radiated pain in the right side, or sometimes in high appendicitis, or sometimes, as you know, the appendicitis pain starts in the periumbilical region and then shifts to the right iliac fossa, but it can be in that region as well. So the other thing is perforated ductal ulcer and acute pain. If somebody gives a history of dyspepsia in the past and history of taking NSAIDs, non-steroidal anti-inflammatory drugs for joint pains or some other conditions, and suddenly they have this severe pain. So that's the differential diagnosis you should think of. Perforated peptic ulcer is very important, and you shouldn't miss that. because it's not only pain, it's guarding in the upper abdominal region and sometimes in the whole of the abdomen. It's a condition called peritonitis. When something perforates, it's usually, most of the time, it's usually duodenal perforation and less commonly than duodenal gastric ulcer perforation. So, and the, after the examination of guarding and peritonitis, you should always get the erect chest X-ray to see if there's a gas under the diaphragm or not. If there's a gas under the diaphragm, that means it's a perforation. And, you have to operate, open up, and remove, do a thorough peritoneal lavage. These are the terms you should use. Thorough peritoneal lavage with normal saline, wash out whatever is in the peritoneal cavity and close the perforation. So duodenal perforation, you should close it with white glue, that is an absorbable stitches, white glue, and put a patch of menthol. If it's a gastric ulcer perforation, you not only close the perforation after peritoneal lavage, you should also take a biopsy from gastric ulcer because gastric ulcer, which is perforated, it could be malignant. Duodenal ulcers are most of the time, usually, almost always, they are benign, but gastric ulcer, they can be malignant. So you should always do a full quadrant biopsy of the ulcerated area and then do a closure, okay, using absorbable like stitches. Now the other thing is the differential diagnosis you should always keep in mind is the acute pancreatitis. Acute pancreatitis usually is severe upper abdominal pain which radiates to the back, goes to the back because the pancreas is a rich peritoneal structure and gives a, it's quite deep and gives a pain in the back. But they will always, most of the time, if they want to know about pancreatitis, they will give you the figure of, in the scenario, the serum amylase. They'll usually say it's about 2,000, 3,000, and sometimes more than that. So that will give you a diagnosis that this is acute pancreatitis. If they also mention there's a 40-year-old lady, a known case of gallstones. Can you hear me all? Yeah. Uh, I hope I'm not talking to myself. Is everybody listening to me, whatever I'm saying, because it's an important topic, and usually there are a couple of questions on this. If everything is, my voice is clear to you and you can hear it, just let me know. Okay? If you can't hear it, just write it down in the chat group so I would know that some of you can hear that. Now, in acute pancreatitis, there's sometimes gallstone pancreatitis. Okay, if they say that a lady with known history of gallstones comes to you with severe epigastric pain, upper abdominal pain, radiating to the back, and the serum amylase is 3,000. It's national unit, so that you understand that's a high serum amylase, so that your bell should start ringing that, oh, this is acute pancreatitis. And acute pancreatitis due to gallstones, they've given you the history that the patient is known to have gallstones. You should also write it down, the diagnosis would be not just acute pancreatitis, gallstone pancreatitis is the most likely diagnosis. Okay. Now, similarly, these differential diagnosis of acute cholecystitis. Okay. It could be perforated peptic ulcer, could be acute pancreatitis, could be appendicitis. And if you concentrate just on the gallbladder, when you say acute cholecystitis, that means the patients have right hypochondrial pain and it's called Murphy's sign positive acute cholecystitis. When you, during examination, if you press in the under the ribs, right hypochondrium, during inspiration, the patient will catch his breath or her breath. This is called positive Murphy's sign. That means the gallbladder is inflamed. It's cholecystitis, acute cholecystitis. So it will be tender on palpation and deep inspiration. Okay, so that could be acute cholecystitis. But at the same time, I should also mention this thing to understand. Sometimes, a 40-year-old lady, for example, comes to you with just a pain in the right hypochondrial region with nausea or vomiting. And Murphy's sign is negative. You do examination, Murphy's is negative, no tenderness, normal temperature, and there's no leukocytosis. That means there's no inflammation. Do an ultrasound scan, and that shows gallstones. So the diagnosis won't be acute cholecystitis. Acute cholecystitis, you should have positive Murphy's sign, you should have tachycardia, you should have high temperature and high white cell count. Excuse me. So in that case, if it's just without temperature, without high white count, without Murphy's sign, but the ultrasound shows gallstone, and the patient comes with pain, the diagnosis won't be acute cholecystitis, it won't be acute cholecystitis, it will be biliary colic. Okay, because the stone in the gallbladder, let us try to move a little, they cause colic. Or when the gallbladder contracts after meals, it causes pain. There's no inflammation. So your diagnosis will be biliary colic. Okay? So, and the other issues which can be with the gallbladder is that sometimes it's just accumulation of mucus. It's called mucocele of the gallbladder. If that mucus gets infected, turns into pus, then you call the condition as empyema of the gallbladder. It can be, if you say complications of gallstones, say it could be acute cholecystitis, it could be biliary colic, it could be mucocele, it could be empyema, it could be gangrene of the gallbladder, perforation of the gallbladder, and very rarely you get carcinoma of the gallbladder as well. Or sometimes it is suspended with a mesentery. You can get volvulus of the gallbladder. It twists around on the mesentery and can get gangrene or acute pain. So these are things in differential diagnosis, the pain in the epigastric and upper abdominal pain, right hypochondrial region. These are the differential diagnosis that comes into mind. But one very important aspect of the differential diagnosis in epigastric and upper abdominal pain is never ever miss a myocardial infarction. Okay? MI, acute MI can present pain in the epigastric and upper abdominal region. Okay, so always if the patient in 50s or some 60s with epigastric upper abdominal pain, always get an ECG and a cardiac enzymes. Make sure it's not acute MI. You have to exclude that, okay? Because it needs urgent treatment if it's an MI, and we should always keep that in mind. So differential hyperemesis, which is not mentioned here, is an acute MI, can be an acute upper abdominal pain. Always keep that in mind and always mention that you want to exclude that it's not an acute MI. If somebody's a smoker, hypercholesterolemia, and patient of hypertension, diabetes, and they get gastric pain. Always think of MI. Okay, so you need to exclude that before you actually exclude the cardiac problem. Okay, and very rarely you can get acute pyelonephritis. Kidneys also injury to posteriorly, but you can get pain radiated anteriorly. Oh, myocardial infarctions, and sometimes radiation from the right lobar, lower lobar pneumonia in the lungs. When you take a deep breath in, that causes pain. That means there is some element of pleural involvement in pneumonia. So that's another thing. Get the basic investigation, chest X-ray, auscultate the patient's chest, make sure it's not a pulmonary problem. Okay? All these things. In that case, that means you need to admit the patient, examine it again and again, and get the proper investigation of this. In addition to routine investigations, you do full blood count, that is complete blood count, CBC, get the chest X-ray done, and also get the erect chest X-ray to exclude perforation, there's no gas in the diaphragm, get the ultrasound scan, get the ECG, get the cardiac enzymes if you're suspecting it's a cardiac origin. So make sure that you don't miss out on anything. Okay? You should be concentrating on all these aspects when you examine the patient. Okay? Now the next is, let's see. Now sometimes there's a question about I remember there was a question on the surgical anatomy. There's usually one question of surgical anatomy. And they might ask you about the surgical anatomy. This question. Sometime a gallows triangle. Gallows triangle is CALOT apostrophe S. Gallows. D is silent. You can say Gallard's triangle, but it's gallows triangle. Okay. Now, as you all understand that, well, I hope that you know the anatomy of the region. So when you do one of these common operations, you should know what you're dealing with and what you're looking at and what you're trying to remove and what you're trying to ligate. Okay? So as you can see, this is the liver at the top, that's the gallbladder. So you get the right hepatic duct, you get the left hepatic duct coming from the right and left lobe, bringing the bile down into the common hepatic duct. And the common hepatic duct, cystic duct joins the common hepatic duct. Cystic duct bringing the stored bile from the gallbladder into the common hepatic duct. The junction of this, further on, it becomes a common bile duct because it's not only a hepatic duct, cystic duct also joins in, so it's called common bile duct. It's bringing the bile from the liver and from the stored gallbladder bile. Okay, as it comes down behind the first part of the duodenum, okay, goes through the pancreas gland in the C of the duodenum, okay, and opens into the second part of the duodenum. Okay, the first part, second part, the third part, and the fourth part of the duodenum. There are four parts. So it's opened into the second part of the duodenum at ampulla pater. It's also called papilla. And if you have to do ERCP, coming from the stomach down through the duodenum, and you open into that region, okay, you're doing ERCP, you have to do papillotomy, you're making a opening there, open it up, dilate it, and then you, if you want to do remove a stone or putting a stent or whatever in the common bile duct, you can do that with ERCP. That's, that's what the papilla is, papillotomy, okay, or sphincterotomy. There's a sphincter there, sphincter of Oddi. Okay. Right, now one more thing in the anatomy I would like to mention to you. As the common bile duct, which is coming behind the duodenum, opening into the second part of the duodenum, the pancreatic duct from the pancreas gland, it comes and joins. It comes and joins the common bile duct before opening into the second part. So it's not only bile, but it's also the pancreas, pancreatic secretions. They are also opening into the second part of the duodenum through the same opening. Okay? If the duodenal contents, if they go back, if there is some stone there, and all the pancreatic duct and the duodenal contents and the bile, everything, they go back into the pancreas, into the pancreatic duct and the pancreas gland. It can cause pancreatitis. Okay. Now the most important part in the anatomy is that common bile duct and the pancreatic duct joins in together before entering into the second part of the at the papilla. So this is called the common channel. Only that part is the common channel. That's the bile duct as well as the pancreatic duct working into the second part of the duodenum, that is the papilla. Okay. If you look at this, the different arteries coming from the aorta, all right? Different arteries coming from the aorta at the porta hepatis, okay? Going to the left gastric and also going to the hepatic. That's the common hepatic artery, okay? And it further goes on to divide the right and left and gives a cystic artery, okay? The gallbladder. Now, the most important surgical point of view, and you can see the blue one behind the common hepatic arteries is the inferior vena cava. Okay, that goes through behind it, behind the liver, into the caval opening in the diaphragm and up into the chest. So that's the inferior vena cava, that's the aorta coming down here and giving branches to the liver and the gallbladder. The branch of this branch here Okay, it's called gastroduodenal artery. This is surgically very important. If there is an ulcer there at the posterior wall of the duodenum, this is at the back of the duodenum. Okay, this is posterior to the first part of the duodenum. If there is a posterior duodenal ulcer, if that penetrates into this artery starts bleeding into the duodenum and you get hematemesis. Okay? So the posterior duodenal ulcer it can perforate into this gastroduodenal artery. So the bleeding from gastroduodenal artery can give a massive hematemesis in the posterior duodenal ulcer cases. There are other causes of hematemesis. I think we've discussed that before. So, so you should know this anatomy: the left lobe, the liver, the right lobe, the liver, the gallbladder, the fundus itself, the gallbladder, and, and this is the body, the neck, and Hartmann's pouch. There's a little Hartmann's pouch here, opens into cystic duct, and it opens into the common hepatic duct to become a common bile duct. Okay, can you see the cystic artery? Now the callous triangle, we'll come to that in a minute. I'll show you the hope in the next diagram. Now look at that callous triangle. Okay, can you see this is a common hepatic duct? That's the left and the right duct. It becomes a common hepatic duct. You have a cystic duct, and you have the inferior border of the liver. So the boundaries of the callous triangle are inferiorly there is a cystic duct, medially there is a common hepatic duct, and superiorly and supralaterally you can say the inferior edge of the liver. So that's the triangle. And what are the contents of the triangle? Look at this. I've shown you the arterial supply, the cystic artery. Cystic artery goes through it. This is the inferior edge or aspect of the liver. Superiorly, cystic duct and the common hepatic duct. So that's the boundary, and the contents are the cystic artery. Okay. Contents of the gallows triangle, cystic artery. Now why do we need to, what's the surgical importance of this thing? Do they ask about gallows triangle? Well, the reason being, when you're doing a cholecystectomy, you should know exactly where you are. Okay? You should clearly demonstrate the gallows triangle where you can see this common hepatic duct, the common bile duct, this cystic duct. So you ligate the cystic duct to remove the gallbladder. Okay. You ligate the cystic artery, which is supplying blood to this. You ligate these cystic duct and cystic artery. Ligation mean आप इसको टाई कर देते हैं. ओके, टाई कैसे करते हैं? एक इधर टाई लगानी है, एक इधर टाई लगानी है और दरम्यान में कट कर देना है. ओके, ऑलवेज राइट डाउन यू ligate or tie this and this area and divide in between. All right. So that is the gallows triangle. Usually there's a surgical question, surgical anatomy. What are the boundaries and contents of the gallows triangle? Now, if in the contents you write down this, in the content, that's the boundary. Upper edge superiorly is the lower border or the inferior edge of the liver. Medially is from the bariatic duct and cystic duct inferiorly. Okay, that's the boundaries and contents of the cystic artery. And there is a lymph node here at the Hartmann's. That's the Hartmann's pouch I was talking to you about. Hartmann's, sometimes the stone gets stuck there and right at the neck. So that needs an urgent removal because the bile can't go through that and you get infected empyema and that needs surgery. Okay, and there is usually a lymph node there at this junction of Hartmann's with the cystic duct is called lymph node of Lund, Lundh sometimes, lymph node of Lund. All right, so that can be there. So it could be in the contents. You can write it down if you want to get more marks. Cystic artery and lymph node of Lund and some fatty contents. Okay, that's the surgical anatomy of the callus triangle. Always you should know that when you open up, you make sure that you know where the cystic duct. I usually, if somebody is doing it, they call me to show, sir, आके देख लें सारा कुछ ठीक है तो I usually ask them, where is the callus triangle? Show me the callus triangle. And then I ask, where is the common bile duct? Where is the common hepatic duct? So the reason being, if you tie it there, you have completely blocked the drainage of the bile. If you damage common bile duct, you have completely blocked it. Okay? So do not ligate common hepatic duct or common bile duct. स्टूडेंट्स अक्सर वो लिख देते हैं जी वो कॉमन बाइल डक्ट को लाइगेट किया सिस्टिक आर्टरी को लाइगेट वो कॉमन बाइल डक्ट को भाई लाइगेट नहीं करना भाई you will cause jaundice, obstructive jaundice, okay? So during cholecystectomy, make sure that we just ligate the cystic duct. Gallbladder निकालना है ना सिर्फ तो ये cystic duct जो है ये जो gallbladder cyst है cystic है इसको निकालना है ना तो इसके लिए cystic duct और cystic artery को ligate करना है. Alright, ligation. Ligate at 2 points and divide it in the middle. Ligate at 2 points and divide it in the middle. When you do it laparoscopic cholecystectomy, apply a clip there, 2 clips proximally and 1 distally. 2 clips proximally and 1 clip distally. Why apply 2 clips? Sometimes 1 clip can be loose. You don't want bile leakage, so apply 2 clips instead. Make sure they are secured enough. Okay, during laparoscopy, 2 clips, divide in the middle, 2 clips, divide in the middle, and remove the gallbladder. Okay, through a subumbilical port. You can do 3 ports, you can do 4 ports. Nowadays, they're using a multi-port system through a single port. Okay, so single port also some people are doing in the West, not here. We're using 3 ports or 4 ports. 4 ports can be relatively convenient because you can get hold of the fundus, the gallbladder, and lift it up with the 4 port. Right? Okay. Now, let's talk about a bit about pathogenesis. ये gallstones जी बनते क्या हैं कहाँ से आते हैं भाई क्योंकि हर एक को तो नहीं होते फीमेल फैटी फीमेल में ज़्यादा होते हैं और मेल में इतनी males also do get gallstones. You got to keep an eye on this. ये नहीं कि males में gallstones हो ही नहीं सकते. No, you do get gallstones. बच्चों में भी हो सकते हैं. That's another thing. That reminds me another question. वो कहते हैं वो 10 years old boy come with right upper quadrant pain, multiple gallstones on an ultrasound scan. Or फिर कहेंगे the spleen is enlarged. Okay. So what is the diagnosis? The diagnosis is hereditary spherocytosis. The patient, the child, बच्चे को हेरिडिटरी स्पेरोसाइटोसिस है जिसकी वजह से स्पेरोसाइट जो डिस्ट्रॉय हो रहे हैं ब्लड सेल्स जो राउंड स्फीयर बन जाते हैं स्पेरोसाइटोसिस स्प्लीन उसको डिस्ट्रॉय कर रही है गेट्स एनलार्ज जो रैपिड जो आरबीसी जो ब्रेक डाउन हो रहे हैं वो सारे का सारा बाइल एंड एवरीथिंग बाइल सॉल्ट बिलिरुबिन ऑल वो लिवर से सिक्रीट होके and they're forming bilirubin or the multiple black stones, okay, in the gallbladder. So जब बच्चे में है तो इसका इन्वेस्टिगेट करेंगे इसको वो hereditary spherocytosis तो नहीं है. That's another thing you've got to keep it in mind. बच्चों में भी हो सकता है. That means now बाइल में क्या क्या होता है कोलेस्ट्रॉल होता है फीमेल में कोलेस्ट्रॉल प्रेगनेंसी ऐसे भी थोड़ा सा उसकी वजह से हो सकता है बाइल सॉल्ट हो सकते हैं इस सब किसी का भी इम्बैलेंस हो जाए बिलिरुबिन का हो जाए बिलिरुबिन स्टोन होते हैं ब्लैक बिलिरुबिन स्टोन्स आते हैं फॉस्फोलिपिड सो दिस bile contains all these four things. Okay, gallstones are formed when cholesterol or bilirubinate, if they are supersaturated in bile और phospholipids जो है ना ये ट्रायंगल डिस्टर्ब हो जाते हैं phospholipids कम हो जाते हैं और कोलेस्ट्रॉल और बिलिरुबिनेट ज़्यादा हो जाते हैं so you get gallstone. Okay. Okay, continue that. Now initiated by cholesterol or bilirubinate supersaturation. So what happens is small stones, crystals form in the gallbladder, okay, and everything gradually grows on top of that. उसी के ऊपर crystals के ऊपर वो बनते चले जाते हैं और फिर बड़े stone grow कर जाते हैं gradually, okay. Now, what are the different types? It could be cholesterol. अगर cholesterol ज़्यादा है तो cholesterol stones होंगे. उसमें bilirubinate ज़्यादा है तो bilirubin stains होंगे. Usually black or blackish brown. Okay. Now, what are the risk factors? किसमें ज़्यादा chances हैं gallstone बनने के? Family history तो होती ही है. But if somebody's obese, obesity है, overweight है ज़्यादा कम हो सकते हैं. अगर rapid weight loss कर रहे हैं that's nice music. Okay. Rapid weight loss हो रहा है cholesterol बहुत ज़्यादा हो गया है body के अंदर burn the fats still in there उससे क्या gallstone हो सकते हैं. Childbearing age में okay, that's enough. Nice song. Stop it now. Okay, no more music, please. Thank you. Childbearing age में होते हैं multiparity में होते हैं ज़्यादा बच्चे हैं फीमेल सेक्स है first degree relatives हैं drugs यार तो म्यूजिक चल रहा है somebody started the music. Huh? Who's that? Please stop that. Nimra, could you ask somebody to stop this? Raza, Nimra, Amna. Okay, thank you. थोड़ा सा पढ़ लो यार बाद में म्यूजिक सुन लेंगे. Okay, you have plenty of time for music. और एग्जाम में मैं तुमसे म्यूजिक नहीं पूछूंगा. So multi-parity. बहुत ज़्यादा बच्चे हैं तो ज़्यादा चांसेस हैं. फीमेल सेक्स में ज़्यादा political relatives हैं तो ज़्यादा चांसेस हैं. Somebody's on ceftriaxone, say they're most likely to get one of the factors, risk factors also postmenopausal estrogens. If somebody is given uh, estrogen, postmenopausal, कुछ लोग लेते हैं keep themselves fit. Some ladies, okay, so estrogen that can cause gallstones as well. पता नहीं वो slow कर देते हैं उसके bile excretion. Okay, so that's the reason that the estrogen. Due to parenteral nutrition, there's an imbalance that can cause gallstones, ileal disease, resection of the ileum. That's very important. Or you bypass the ileum, then you can have gallstones. This is an important problem. Okay, if somebody's got ileal disease, terminal ileum especially, or that terminal ileum is resected or there's a bypass for that reason, what will happen? The terminal ileum, as you all know, now listen carefully. All the bile salts, they are absorbed in the terminal ileum and they go back to the liver for resecretion. If there is an ileal disease and bile salts are not absorbed, there is a deficiency of bile salts and gallstones will form. Okay? If you resect that in a disease condition, so that bile salts will not be absorbed and there will be deficiency so that you go gallstones formation. So similarly, in Crohn's disease, for example, which used to be called as regional ileitis, that ileal disease, there was a problem that they were getting more gallstones because the absorption of the bile salts from the ileum that was reduced. जो ही वो कम एब्जॉर्प्शन होती है तो उसका पूल कम हो जाता है and if there's a balance of the ileal salts is reduced to gallstones. Risk of and increasing age, people do get with increasing age. These are the risk factors. Majority are overweight, obese females, distant relatives, and somebody's on estrogen or some ileal disease, they get gallstone problem. Now, the clinical presentations, okay, now look at that. The gallstones may remain symptomatic, being detected incidentally as imaging is performed for other symptoms. अब कोई खातून आई है आके उन्होंने कहा जी मेरे पेट में दर्द होती है, खाना खाते ही पेट फूल जाता है, गैस बढ़ जाती है, हवा बढ़ जाती है, नौसिया से होना शुरू हो जाता है. आपको पेन शेन कोई नहीं है तो इंसिडेंटली आपने अल्ट्रासाउंड किया है तो पता चला है कि वो अल्ट्रासाउंड gallstones are okay, so they are called sort of asymptomatic incidental gallstone. ये काफी परसेंटेज ऐसी है. अगर आप 100 बंदे पकड़ के ले आए, 100 औरतें ले आए और उनको कोई इतना प्रॉब्लम ना हो, उसके अल्ट्रासाउंड करेंगे तो उनमें हो सकता है 5-10% या 15% तो gallstone निकले. If they're asymptomatic, not causing any problems, so you leave them alone, don't do anything. Okay? Sometimes strong history and patient getting problems, in that case, we do advise for a cystectomy. If symptoms occur, patients typically complain of right quadrant pain or gastric pain, sometimes radiates. वो कॉस्टल मार्जिन के साथ साथ पीछे तक रेडिएट करती है. This may be colicky, but more often it's a dull and constant pain. Okay? Dull and constant pain. Especially postprandial dyspepsia या pain चलता है. Other symptoms include dyspepsia, पेट में हवा भर गई, हजम नहीं हो रही कुछ चीज़, और sometimes food intolerance के ये खाऊं तो वो पेट मेरा फूल जाता है, particularly to fats. Okay. Or sometimes alteration in bowel frequency, sometimes diarrhea or constipation. So clinically, they can be asymptomatic, they can be symptomatic. Okay. Now, biliary colic is typically present in 10 to 25% of patients. ये मैंने आपको इसकी कॉम्प्लिकेशन में एक चीज़ बताई थी. Biliary colic. That means patient has pain, but no temperature, no raised white count, and no Murphy's sign positive. Okay, so that is biliary colic. If you get all these present, positive Murphy's sign, raised temperature, raised white cell count, this is acute cholecystitis. Okay. This severe right of quadrant pain associated with nausea and vomiting, and pain may radiate to the chest. So that's biliary colic. What are the ultrasound investigations you do? Stones, and you can also say what is the diameter of the CBD. CBD normal diameter is up to 7 millimeter. If the diameter of CBD is raised 9 millimeter or more than 1 centimeter, that means CBD is dilated and there is a suspicion of a stone in the bile duct. Okay, so keep that in mind. And patient will get jaundiced or can get cholangitis if there are shivers, temperate temperature, say high fluctuating temperature and shivering. Attacks of cholangitis can be there. So that's another complication of gallstone is gallstone cholangitis. Okay? And if the stone stuck there, it can cause obstructive jaundice in the bile duct. So plain radiographs can show calcifications. You can do an MRCP, magnetic resonance, cholangiopancreatography. That is, you can, if you're not sure about the anatomy, then that will change the anatomy and the stones in the gallbladder or the bile duct. You can do a CT scan. That will show the anatomy of the liver, gallbladder, pancreas, cancer. If you do HIDA scan, radioisotope scan, that will show you if the gallbladder is functioning or not. If the gallbladder is non-functioning, that means that you need to do removal. Okay. ERCP, endoscopic retrograde cholangiopancreatography. आप मुंह के थ्रू एंडोस्कोप डालते हैं, एंडोस्कोपिक, और सेकेंड पार्ट ऑफ ड्यूडिनम से रिट्रोग्रेड नीचे से ऊपर बाइल डक्ट की तरफ आते हैं, एंड कलेंजियो बाइल डक्ट की पिक्चर लेते हैं और पैंक्रियाटिकोग्राफी और पैंक्रियास डक्ट की पिक्चर लेते हैं. Or it's not only diagnostic, it can remove the stone, you can put the stents, you can take a biopsy. So all these things, these are the advantages up to me. ERCP, not just the investigation, getting a CT scan. ERCP is an ideal one. Okay? Not only you diagnose it, you treat it, and you can also see the pictures as well as remove a stone, pass a stent in, case of structure, benign or malignant. The other investigation is PTC, that is percutaneous transhepatic cholangiography. You can't negotiate the RCP through the papilla. It's difficult. You can do percutaneously over the liver, right side way. You can go through the liver with the needle, and when you aspirate a bile, that means you are in one of the biliary radicals. So you inject a dye or a contrast, and that will go into the liver and comes down into the bile duct. So that will show you the anatomy and if there's any really biliary strictures or if there's any problem there. So PTC or also an investigation. Endoscopic ultrasound. आपको मुंह में एंडोस्कोप डालते हैं, गैस्ट्रोस्कोप, goes down in the stomach, in that region, and you do endoscopic ultrasound, जो आपको न सिर्फ स्टमक के बारे में बल्कि उसके around the gallstone, the CBD stone, that can give you a picture. So endoscopic ultrasound not only give you the anatomy, also you can detect stones. Okay, and I'll show you some of the pictures. And see the calcification of the gallbladder. Okay, so that's the X-ray picture. Show the gallbladder calcified wall. Okay, and about 10 to 15% cases of plain X-rays. Okay. आपने एक्सरे करवाया, उसमें ये पिक्चर आ गई है, तो ये देखो गॉल ब्लैडर में ये मल्टीपल स्टोन्स आ गए. Okay. So these are multiple stones in the gallbladder. Okay, yeah, that's the lumbar spine. Okay, that's the transverse process of the spine, and you can see there's multiple stones, and there is a suspicion of small stone there as well. Okay, so that's the iliac bone, lumbar spine. You've done a plain film, so 10 to 15% of the gallstones are radio opaque. आप एक्सरे लेते हैं तो उस एक्सरे पे नजर आएगा. But if you look at this, that's a CT scan. Now that's the back, that's the spine region, that's the anterior region. Now that's the liver. When you see outside the liver, you see these ribs, okay, and the muscles. Ribs and the muscle. That's the right lobe of the liver, the left lobe of the liver. Okay, these are the vertebral bodies. You see this. This is the aorta. These are the kidneys. That's the spleen. All right. That's the stomach and the bowel, and that's the pancreas gland. Stomach के पीछे, pancreas. Okay. You come as close to this is the gallbladder. You can see the calcified area wall of the gallbladder. Okay. Sometimes you can see this gas in the gallbladder. Gas in the gallbladder in a diabetic patient, that means you got something about it. Okay. And there are multiple air fluid levels in the bowel as well. So there is a possibility that there's a stone stuck in the ileum causing ileal obstruction. Okay, it's called gallstone ileus, and there is a cholecystoduodenal fistula. Okay, that's possibly the duodenum. The gas there, gas is flowing through that fistula into the gallbladder. Okay, so that stone has come out from the gallbladder into the duodenum and has caused distal obstruction in the small bowel. Right. Now look at the ultrasound scan. Now, the terms used. This is the gallbladder wall. Now these are the stones. The term used is acoustic shadows. When you see these black lines coming from the stones on ultrasound scan, these are called acoustic shadows. ACOUSTIC. Acoustic shadows. They are of gallstones. Okay, so that's in the ultrasound scan. That's the liver. Okay, and see some dilatation below in. Now this is the endoscopic ultrasound scan. You've gone through the esophagus. You can see the dilated bile duct, common bile duct. You can see the pancreatic duct. So this the scope is still inside the esophagus and the stomach. So you can see all around. Okay, see the liver. You can see the bile duct. You can see the pancreatic duct. Now that's the CT scan. You see this multiple gallstones there in the liver. Okay, in the gallbladder. That's the stomach shadow. Gas, gas is black, and this is probably tip of the NG tube. Tip थोड़ी सी रेडियो opaque होती है. Okay, so that's the liver. That's the gallstones in the gallbladder. That's the stomach region. That's the aorta. That's the inferior cava, and this is the vertebrae in the back, and the muscles, the back muscles. All right, that's the spleen. Okay, that's the Hyder scan. Okay, that's the liver, and you see the biliary radicals. Hyder scan. I'll tell you sometime when do you do these and what is the importance. And this is the area which seems not right, so there's a possibility of some pathology there in that region of the gallbladder. Okay. All right, next. Similarly, that's another CT scan. This is a PD cutaneous transhepatic. You see the biliary dilatation injected there, and there's possibly some blockage in the bile drainage. That's why this is dilated. Now this is the ERCP picture. You see this is a scope coming from the stomach. Go down through the papilla, you pass a catheter, inject a dye. This is a CBD. That's showing the right hepatic duct, the left hepatic duct, and that's the cystic duct and the gallbladder. Okay, time हो गया. That's the ERCP. You can see the scope there. I'll show you another in a minute. So that's an ERCP, and that's a stone there. Okay, it's a stone in the common bile duct. Done the picture, endoscopic retrograde pancreatic cholangiopancreatography. That's the bile duct, and you can see the stricture there. Okay, stricture in the, it could be malignant structure, right? Similarly, this is dilatation of the biliary radical, and see multiple stones in the common bile duct. Multiple stones in the common bile duct. Now, what are the effects and complications? We'll take it from there. I've shown you about 36 slides, and we'll continue from that in the next lecture, maybe on Wednesday, I think. Yeah, okay. Thanks, and goodbye.